Welcome back to the second part of medical emergencies in the dental office. Coma in diabetic patient. Diabetic patient who suddenly loses consciousness. Is this a hypoglycemia or a hyperglycemia? What's the difference? Hypoglycemia is of a rapid onset. Hyperglycemia is of a slow onset. In hypoglycemia, there's irritability. In hyperglycemia, there's drowsiness or disorientation. Hypoglycemia, there is moist skin. Hyperglycemia, dry skin and mouth. In hypoglycemia, the pulse is full and rapid. In hyperglycemia, the pulse is slow and weak. Hypoglycemia is more common. Hyperglycemia is rare to see, especially in the dental clinics. Very rare because it is slow onset. The patient is unwell for some time, so he cannot go to visit the dentist while he is unwell. Hypoglycemia is less severe. Hyperglycemia is more severe. Hypoglycemia is easy to be managed. Hyperglycemia is difficult to be managed, and there is dehydration. Acute hypoglycemia, the causes are overdose of insulin and not eating on time while taking his treatment. The management is to give glucose tablets or powder. If unconscious, give 50 milliliters, 50% glucose IV, or give subcutaneous glucagon 1 milligram. Thyroid crisis or thyroid storm. This is sudden severe exacerbation of hyperthyroidism. Precipitating factors: infection, surgery, general anesthesia, trauma, pregnancy, and other physiologic or emotional stress. Manifestations include hyperpyrexia, fever, palpitation, tachycardia, agitation, nausea and vomiting, abdominal pain, loss of consciousness which can be partial or total. The management: terminate dental treatment, call medical assistance, oxygen, monitor the vital signs, initiate the BLS, the ABC, if necessary, start IV line and fluids, and transport to the ER in hospital. Steroid crisis, there's circulatory collapse. It's due to adrenal insufficiency, adrenocortical insufficiency. Primary, this is Addison's disease, although this is a rare disease. Secondary, due to exogenous treatment, and this is more common when a patient is taking corticosteroids in the dose of 20 milligrams cortisol per day for more than 2 weeks in the previous year. This can lead to inhibition of the suprarenal cortex, and when the patient is faced or exposed to a stressful condition, the inhibited suprarenal glands cannot provide the necessary corticosteroids to cover the patient in this stressful situation. Causes are stress conditions like general anesthesia, surgery, trauma, and infection. Signs and symptoms: there is pallor, weakness and nausea, rapid weak pulse, hypotension, and loss of consciousness. Management: lay the patient flat, raise his legs up. Hydrocortisone 200 milligrams IV, oxygen, start BLS, basic life support if necessary, call the ambulance. Bronchial asthma. What can bring an attack of bronchial asthma? Number one is anxiety, infection, exposure to allergens, and not bringing the salbutamol inhaler to the clinic. Signs and symptoms: there is breathlessness, cyanosis, expiratory wheeze, rapid onset, rapid pulse, mental confusion. Management: reassure the patient. Do not lay the patient flat. It's not necessary. Not all emergencies will put the patient flat and raise his legs. Give inhaler, the inhaler usually used, which is the one the patient usually uses and the one that the patient brings with him to the clinic. Oxygen, adrenaline only in children, hydrocortisone 200 milligrams IV, monitor the vital signs, and if no response, call the ambulance and transfer to the ER. Angina. Angina is acute chest pain which may radiate to the left arm or shoulder. Management is by glyceryl trinitrate spray or sublingual tablets, and spray is preferred. Oxygen, aspirin 300 milligrams. If symptoms do not resolve rapidly, if they last more than 25 minutes with the administration of GTN, and which can be repeated for a second dose, consider it likely that the patient has myocardial infarction. Myocardial infarction. Signs and symptoms: severe crushing retrosternal pain that may radiate to the left shoulder, arm, or jaw for more than 20 minutes. Continuous pain for more than 20 minutes. Not relieved by stress and not relieved by glyceryl trinitrate spray or sublingual tablets. There may be associated symptoms like severe sweating, like nausea, like vomiting due to autonomic stimulation. Management: call the ambulance. Comfortable position allowing easy breathing. Oxygen only. Aspirin 300 milligrams. And avoid narcotics for pain initially so as not to interfere with differential diagnosis. Cardiac arrest. Causes are myocardial infarction, hypoxia, anesthetic overdose, anaphylaxis, and severe hypotension. Signs and symptoms: unconscious and pulseless. Management: call for help immediately. Patient, put him on a flat, firm surface. Clear the airway, keep the airway patent. Start the cardiopulmonary resuscitation, defibrillation, and transfer the patient to hospital. Stroke, cerebrovascular accident, CVA. Signs and symptoms: severe headache, unilateral weakness or paralysis of arms or legs, unilateral facial paralysis of the upper motor neuron lesion, not like the Bell's palsy. Bell's palsy is a lower motor neuron lesion. Difficulty or inability to speak, partial or total loss of consciousness. Management: reassurance, supine position and the head slightly elevated, and BLS if needed. Transfer to hospital immediately. Convulsions and epilepsy. Predisposing factors: anxiety, hunger, menstruation, alcohol, external stimuli, flashing lights, non-compliance with medications. Signs and symptoms: at the beginning there's a warning cry and followed by immediate loss of consciousness. Rigid tonic phase at the beginning, followed by the clonic phase where there's widespread convulsions and jerking. Vomiting, flaccid after a few minutes. Consciousness is regained after a variable period. Patient may remain confused after the end of the attack. Management: prevent the patient from harming himself. Place in a supine position at the beginning. Maintain a patent airway. No medications, just await recovery, which will occur spontaneously in most cases. And after recovery, put the patient on his side. This is the recovery position. Give him oxygen. Monitor the vital signs, suctioning for any mucus secretions, and reassure the patient on recovery. Status epilepticus. It's a continuous or repeated convulsions for 5 to 15 minutes. During the period of convulsions, the patient suffers from severe anoxia because breathing is not regular. Breathing may stop during the period of convulsions. Management is to give 10 milligrams midazolam IV and repeat it if no recovery within 10 minutes period. Maintain an adequate open airway, give him oxygen, call an ambulance, and transfer to hospital. Emergency kit and drugs. We need to have an oxygen cylinder, ambu bag for hand ventilation, disposable airways with different sizes, disposable syringes, different volumes, suction, automated external defibrillator, glucose measuring device, cannulae, different sizes, portable suction equipment, sphygmomanometer for blood pressure measuring, and pulse oximeter. As for the drugs, the medicine, adrenaline 1 to 1000 concentration ampoules, GTN glyceryl trinitrate spray, aspirin 300 milligrams, hydrocortisone 100 milligrams vials, chlorpheniramine, which is the antihistamine, salbutamol inhaler for the bronchial asthma, morphine sulfate tablets, midazolam, glucagon 1 milligram ampoules, and glucose or dextrose injection 50%. Thank you very much.